Thank you so much for joining us today. And I'm going to be talking about healthcare under the Trump administration, impact on employers and employees. So let's start. Just a moment. Okay, so apologize. All right, here we go. Sorry, I think we are having as much trouble as Congress is with healthcare reform. So here, just to give you a quick idea of what I'm going to talk about today. First, I'm going to talk about the President Trump's executive orders and what that potentially means for employers with an expansion of association health plans, short-term insurance, and some renewed emphasis on HRAs or health reimbursement arrangements. I'm also going to talk to you a little bit about the elimination of the cost-sharing reductions. It's been in the news a lot, as well as try to bring you up, at least as it currently stands, on the legislative efforts for healthcare reform. And I'm going to talk about the one act that actually has passed through a body of Congress, the American Health Care Act, which was passed by the House. So I'm also going to talk about the stalled Senate bills very briefly and about future legislative efforts. And then what I think is next for healthcare reform. I'm going to talk to you a little bit about the individual mandate debate that is going on right now and some renewed emphasis on the employer shared responsibility payments, the employer mandate, and also some new FAQs that just came out about the assessment process on that topic. Okay, so let's start first with the President Trump's executive order. And on October 12th, he signed his executive order, and now they always have these very interesting names, promoting healthcare choice and competition across the United States. So in this executive order, he attempted to expand access to association health plans, which I'm going to explain in a little more detail in a moment. He also asked for expanded availability of the short-term limited duration insurance and availability and use of health reimbursement arrangements. So specifically, the executive order requires the DOL to consider proposing regulations or revising their guidance to expand access to health coverage by allowing more employers to form association health plans or AHIPs. So under the current law, just to give you a little background in case you're not familiar with association health plans, they are multiple employer welfare arrangements, or MWAs, and you may have heard of that, under ERISA and state insurance law. And MWAs can either be fully insured, meaning it's covered by insurance and their premiums paid, or self-insurance, where basically the association itself pays all of the claims and there is no insurance. So insured MWAs are subject to state regulations in the state in which they operate. And then the right now, self-insured MWAs are subject to broad state regulations in all of the states in which they operate, which is different than, as you know, any of you that are familiar with self-insured group health plans under ERISA, they are not subject to state insurance law. They are exempted or preempted by ERISA. So the current law provides that if a MWA is covered by ERISA, if it's a bona fide group or association of employers. And of course, that's a technical term, and it revolves around commonalities of interest among the participating employers. So it needs to be a group of employers that are connected, for example, a group of universities or something of that nature. And it has to be controlled by those participating employers. And now participation is limited just to employers. You can't have individuals or sole proprietors, just employers. So as I mentioned, if the MWA is not subject to ERISA, it's subject to unlimited state insurance regulations. And the way that MWAs or association group health plans are regulated is right now, most of them are subject to small group market requirements. And the reason that's important is when you're subject to small group market requirements, you have some very specific requirements that you're required to meet, with regards to things like the size of the group, what kind of benefits you have to provide, what kind of rating you use, those sort of things. So under this executive order, the DOL is asked to issue regulations exempting self-insured MEWAs from state regulations. Now, what that would mean is if you had an association health plan that was self-insured, it would become more like a regular employer group health plan that's self-insured and would be subject only to federal law, not to state law. And that would make a big difference if you had a MEWA that was in multiple states, because right now they have to comply with each different state, but in this case they would not have to do that. And then the other thing is that the DOL may also revise is an interpretation of what is an employer and what is a bona fide group of employer. So what they're requesting is that it is a broader commonality of interest standard, where it could be something as simple as the same line of business. So let's say everybody in the restaurant business or everyone who is a distributor, and possibly something as simple as geography. Everyone in Waycross, Georgia, for example. So all that is one of the other changes that the DOL is requested to look at. And the other thing is to allow participation, not just by companies, but also by sole proprietors, meaning, a small one-person business, and individuals. So what would this mean if the association group health plans is expanded? Well, first of all, it would definitely allow employers more choice of insurance coverages, because you could see, various groups like insurance agents or, like I mentioned, restaurants or others set up association group health plans that employers in that industry could join. The other thing is, because of the way that it is going to be, if it's self-insured, is that it may be exempt from consumer protections that apply to the individual and small group market. Because as I mentioned before, they may not be subject to the rating rules and coverage and things that now apply in the small group and individual markets. One of the other things that has been discussed is it may not be required to be guaranteed issue. For example, it could be that you can charge different premiums based on health status, which is something that you certainly can't do right now in the small group market. And then lastly, you may not be required to cover all of the essential benefits of the Affordable Care Act. And just as you may remember, the essential benefits are all of these standard benefits: hospitalization, pharmacy, maternity, outpatient, all the things that have to be covered under the Affordable Care Act. Now, let's look at the other side. In the old days, back a long time ago, association health plans had a very bad reputation, which is why some of the changes, some of the current regulations came into place, because they were set up and in many cases they were completely fraudulent, and they took your money and you got no benefits. So you were paying premiums, but you never really got any care. The other thing is, if they're not properly funded, then potentially there is also a risk of insolvency of that plan. Now, one thing that's been mentioned, some of the critics of this expansion, is that it becomes an uneven playing field, because you got the fully insured market, which has to abide by state regulation, and then you would have these association health plans that did not. So what that may result in is higher premiums and less plan choice in those individual and small group markets. But conversely, that means that for individuals who are participating in the association health plans, it may be better for them. And one of the other things about it is that an association health plan, you could target it based on, for example, the market that you're serving. For something like restaurants, let's take restaurants for example, because individuals move around in restaurants. If you had an association health plan, the people could potentially just stay covered even if they changed restaurants, which is something that may be helpful, and also could target the specific benefits of that association plan to match the needs of that particular market. So that is what's happening with association health plans. So where we are now is we're waiting for additional guidance from the DOL as they're going back and looking at changing these regulations. So the next part of Trump's executive order was about short-term insurance. And short-term insurance right now, the current policies are limited to less than a 3-month period. They're not renewable, and they are not considered minimum essential coverage or MEC under the Affordable Care Act. So that means that if you are an individual and you had a short-term insurance policy, it would not meet the individual mandate that you have required coverage. And one other thing about that is the ACA consumer protections don't apply. So for example, under the ACA, your flu shots are covered 100%, mammograms are covered 100%, well, visits are covered 100%, I'm sorry, I should say physicals, but under the short-term insurance, you can allow for cost sharing for those preventative services. And then the other big difference is right now, as you know, under the Affordable Care Act, there's an out-of-pocket maximum for individual coverage for family coverage. And once you hit that maximum, everything else is covered, generally if you stay in network for the coverage that you have. Well, under the short-term insurance requested changes, there'd be no limits on the out-of-pocket maximum. So you could make those higher than you have in a standard policy. So what would this do? So to begin with, to do this, they would have to allow longer coverage periods. And it used to be, before the most recent change, it was less than 12 months. The other thing that they're thinking about allowing would be renewable coverage. So let's say that you had a short-term insurance policy that was supposed to last less than 12 months. Well, you would be able to renew that, and there is a question of how many times, once, twice, that's still in the unknown category. And then the other thing is they would like for it to be considered minimum essential coverage or MEC, so that for an individual, if they have one of these less than 12-month policies, that counts towards their individual mandate, and therefore they're not going to have a penalty. So if they do that, if they make these changes, well, what's the impact? Well, of course, first, the biggest impact is in the individual market, because as you can tell, based on what I've talked about being in it and not being required to be in it, it's going to be cheaper, most likely, than coverage in the exchanges for individuals. So healthy individuals may definitely think about choosing this coverage as opposed to choosing the other coverage. So the premiums could be less, and you may actually see some employees drop out of more expensive employer coverage and take this coverage. Now, as an employer, that's not a major concern unless you need a certain number of your employees to be in your plan in order to meet your contract terms, for example, with your insurance company. But it is something to think about. Now, one thing it could reduce, which would be beneficial for most employers, it could reduce COBRA enrollment. Because if someone terminated your employment, instead of taking an expensive COBRA policy, they may just choose to take one of these short-term insurance policies. So back to this. So talking about the short-term insurance. So this is what we are waiting to see, and they are supposed to be working on revising these regulations. And I think this one is going to be a little easier to do than the association health plans, because as you can tell, it's not near as complicated, and the longer coverage periods actually used to be allowed. So it would be an easier change. So the last topic of this executive order was the health reimbursement arrangement, or HRAs. And HRAs have been around for a long time, but there were some changes made under the Affordable Care Act, which I'll get into in a minute, which made them not as useful as they used to be. So this executive order directs IRS, DOL, and HHS, Health and Human Services, to propose regulations that will increase the usability of HRAs, because like I said, the Affordable Care Act really put a limit on the use of HRAs, and allow employers more abilities to offer HRAs, and allow HRAs to be used in conjunction with non-group health insurance. Now, I am going to talk a little bit about the small, the QSERA as it's called, the small employer HRA that is allowed right now. But generally, an HRA, general purpose HRA, cannot be used with non-group insurance. Okay, so current law, just to remind everybody. First, HRA is account-based plan that it provides for reimbursement of qualifying expenses. It's funded solely by the employer. There can't be any employee contributions in it. And it's currently available only to current and former employees and their spouses and dependents, which roughly that's really who you would definitely typically want to cover. And it is subject to tax non-discrimination requirements that apply to self-insured group health plans. And that means that you have to offer it in a way that's non-discriminatory. For example, you would offer HRAs across the board to all your employees. You couldn't limit it just to highly paid employees. So at this moment, except for, like I mentioned, for the QSERA, you have to integrate the HRA with other group health plans, health coverage. So how that typically works is you have an employer that has a group health plan, and let's say it has a $2,000 deductible, and that employer may give those employees their HRA where it will pay up to, say, $500 or some other amount of that deductible through an HRA or through a reimbursement. So that would be considered integrated because you have to be covered under the group health plan to get the HRA. And right now, except for the QSERA, you can't use an HRA to pay individual insurance premiums except for accepted benefits like dental vision. Okay, dental vision coverage, which is a separate coverage, you can use HRAs for that, but that's not the general use. So as I mentioned, the 21st Century Cures Act added the Qualified Small Employer Health Reimbursement Arrangement. And this is a special provision just for small employers with less than 50 employees, and they can provide standalone HRAs to reimburse individual health insurance policies. There are lots of conditions associated with it, including the maximum reimbursement amount that can be provided and who you have to provide it to. So it is a very limited, basically, workaround to the current law. So what could be done? How can they make changes? Well, first, the big thing is to allow standalone HRAs for large employers. So for example, instead of the QSERA where you have to be less than 50 and there are limits on how much you can reimburse, to allow an employer to have a payment plan that would allow its employees to purchase individual health insurance coverage, but the employer could provide an HRA to fund it. And depending on the HRA, potentially the other thing is for it to be considered minimum essential coverage for the individual and employer mandate. So it would count both towards your employees' requirement to have health coverage and your employer required to have health coverage. So this is something that is a very hot button right now, and we are expecting some guidance to come out because, again, this is going to be a little bit easier to do than the association health plans, which there are lots of laws and regulations that have to be rewritten to allow for that. So now we finished talking about the executive orders, or this particular executive order. So, the point of the executive order is that to the extent that Congress doesn't act and doesn't pass legislation, it basically is asking for legislation through regulation. because so many of the areas in this particular group of laws is very regulatory, which means that there are a lot of changes that can be made just by regulation. So you could see major changes taken through these executive orders, and you should be on the lookout for those. So now let's switch to something else that I'm sure everybody's heard about lately, and this is the cost sharing reductions. And as a reminder, these were payments that were made to insurers to pay those insurers back for providing subsidies to consumers. So if someone went to the healthcare exchange under the Affordable Care Act and they signed up based on their income and there were a number of people covered, they generally would get a subsidy in terms of how much they would have to pay for their premium, and that subsidy would come right off the top. So for example, if a policy for a family of 4 was $1,000 based on their income, if they qualified for a subsidy of $500, then that individual would be billed $500, and that $500 subsidy was being reimbursed to the insurer by the government. So what happened was the House Republicans sued to block this on constitutional grounds, basically because these payments were done without there being anything specific in the Act, in the Affordable Care Act, requiring it. And that therefore, because Congress is the only one who can appropriate funds, administration can't make that decision. So the courts have agreed with that and decided that those subsidy payments to insurance companies are illegal. So what happened is the Trump administration made the payments to the insurance company for September, but they haven't made any since then. So insurance companies were prepared for this because they knew the political climate, they saw what was going to happen. And so what they have done is they prepared by raising premiums. And I know you've seen lots of things about how much premiums have gone up, but specifically the CBO, which is Congressional Budget Office, has estimated that there's a 20% average premium increase in 2018 if those cost sharing reductions were halted, and $194 billion net deficit increase by 2026. Because as you know, the CBO, they are supposed to look at every bill and every action and determine what the expense associated with it is. So in this case, what has happened in 20% average, I will tell you that I have definitely seen in some particular states where the expenses have, they've had to double the premiums in the individual markets, or 40%. So I would say 20% is on the lower side of that. So as of now, it does not look like there'll be any additional payments made. And although some lawsuits have been filed, it isn't likely that they will be successful because the decision has already been made that these payments are illegal. So what is happening on the legislative efforts for healthcare reform? As you know, it's very, and it's in the news every single day. So the Republicans control the House, Senate, and the presidency, at least appear to. And many of the Republicans campaigned on repeal and replace, but the Democrats are united. So it appears that the Republicans are not as united as the Democrats. And so in one of the other things is it appears that voters may be changing their minds about repeal and replace. Recent elections, there have been some pushback, and some Democrats have been elected in states where it would have, in the past, would have more typically been a Republican. And one of the reasons was related to healthcare reform. So it could be that there is a shift in public perception, but honestly, there haven't really been enough races to determine. The mid-year elections will actually be where we will find out if the mood of the public has changed with regards to healthcare reform. So the one act that actually has been passed was the American Health Care Act, and it was a partial repeal of the ACA. And back on May the 4th, way back then, it was actually passed by the House. And it was originally designed to go through the Senate through the budget reconciliation process. And that is a process whereby Congress can choose one bill that gets an expedited review without being subject to the Senate filibuster rules, which essentially allows someone to filibuster and stay on the floor and keep a bill from being voted on. So unfortunately, that deadline is passed. So this act by itself is not going to get passed as is. However, it is still the only bill that has been passed by a House. And it is not inconceivable that the Senate could come forward with another bill very similar to this and get something passed. So what did it do? It repealed the mandates, both individual and employers. It repealed the Medicare surtax, the nest investment income tax, limit on health flexible spending arrangements. It got rid of that. It expanded health savings accounts and made some changes in tax credits. So it made a lot of changes, and it did keep some of the popular reforms like the prohibition of limited and annual dollar limits, preventative benefits without cost sharing, maximum out of pocket, covering dependents age 26. So it also doesn't allow for you to charge someone with a pre-existing condition more, but unless someone lets their coverage lapse, or potentially in case someone in a state where they go to a high risk pool, which is something that potentially could happen in the future. So it also provided more flexibility to the states in 2020 that they could change their own essential health benefits. And the community rating, that they can allow a higher rating for pre-existing condition, and they could set up the high risk pools, as I mentioned. And also the age rating is expanded. That is the number of ranges that you can have based on how old someone is. So it made some changes to Medicaid, prohibiting additional expansion of Medicaid and changing funding to per capita block grants beginning in 2020, and giving the states the option to require employment for non-disabled, non-elderly, non-pregnant beneficiaries. And just as a reminder, Medicaid originally was only provided to disabled, elderly, pregnant, or mothers and children were the people that were covered by Medicaid. And then the Medicaid expansion under the Affordable Care Act extended that also to other individuals, including men and women without children. So, excuse me. So basically, the American Health Act changed all of this. But, it hasn't been passed. It was passed by the House, but in the Senate, we had the Better Care Reconciliation Act, which was supposed to be similar to the House Act. And it gave additional flexibility to the states. And there were several variations that came out. I decided not to cover them because we know now at this point nothing is going to happen. Then there was the Healthcare Freedom Act, which was what they called skinny repeal, that just did a basic repeal but left other things in place. And then we had the Graham-Cassidy healthcare bill, which was actually a bipartisan attempt to not to repeal, but to make some changes to the Affordable Care Act. But as you know, none of this passed. Nothing happened. Lots of discussion, lots of things brought to the floor, but nothing has happened in the Senate. Honestly, one of the reasons for that is because although the Democrats are voting as a bloc, the Republicans really are not. You've got ultra conservatives, you've got moderates. So because of that, the Republicans have not held together in the same way that the House did when they passed their version of this. So what's going to happen? Well, as I mentioned, the budget reconciliation expired September 30th. So how can they get something through? So what has to happen is some repeal can be put into the Tax Reform Act, which is currently under consideration. And I'm sure you've been reading about that in both the House and the Senate. And then if that doesn't work, it could come back next year. So they could try it in 2018 or 2019. And then also the bipartisan improvements, I mentioned a little bit about that. And then the Common Sense Reporting Act of 2017. I just love the names of some of these acts now, which was basically to change and eliminate a lot of the reporting that employer would have to do in terms of getting rid of those tax returns that you have to send to every individual. So, what's next? So after all of this legislative maneuvering back and forth and posturing, there have been 9 months of that. And so basically, at least officially, Congress has stated that it's moving on to the challenge of reforming the US tax code. As you may know, recently the Trump administration passed their 1-year mark, and they feel they need to have something to show for it. And because it didn't seem that they could get traction with regard to the Affordable Care Act, they have moved on to the tax code. So while this is really not, it's a shift in priority in one way, but on the other hand, don't be surprised if you don't see something about the Affordable Care Act sneaking in. So the House tax proposal that was released, it did not repeal the individual mandate, and it didn't fund any tax reform for Medicaid. But the Republicans in Washington are not done with healthcare reform. And, as you know, a lot of backdoor and backroom maneuverings are still taking place. So on the 2nd of November this month, the version that was introduced by the Republicans was called the Tax Cut and Job Act. And the CBO, when they did the projection that it will increase budget deficits by $1.7 trillion over 10 years. And it will cause the US debt to rise more than the current projection. So the House is looking for other ways to raise revenue to offset the tax cut. Well, one way to do that is to eliminate the individual mandate. And while this sounds a little bit counterintuitive, basically repealing the mandate would reduce the federal deficit by $338 billion over the 2018 through 27 time period. But it would do that by increasing the number of uninsured people by 4 million in 2019 and 13 million by 2027. So in this tax bill right now, just so you know, a couple of things that are included in it is it would eliminate the deduction that employees can claim for employer-provided educational assistance. Employees would have to pay taxes on the benefit, and employers would have to pay the FICA. It would also repeal the exclusion for employee achievement awards. So no matter what achievement award you gave to your employees, they would be taxed on it. It would count as compensation. Also, the employer-provided dependent care assistance programs would be repealed and would no longer be allowed. And there would be no deduction for transportation fringe benefits, such as bicycles and things like that, on-premises gyms and other athletic facilities or amenities that are provided to an employee that involve the property or services not directly related to the trade or business, except to the extent that the benefits are treated as taxable compensation or included in gross income. One of the things that potentially could cover would be, for example, an employee cafeteria. And then that would be taxable compensation to the employees, which obviously most employees would not want to pay taxes on their employer-provided meals. So the other thing, as I mentioned, employer-provided childcare. For example, if your employer actually provides a child care facility, right now there's a credit for that. Well, the credit would be eliminated. So that means that the employer would no longer be a tax deduction to provide any kind of daycare facility at their plant or location. And if, for example, meals and housing, if they were provided to employees by employers, that would also be eliminated. And the reason for eliminating all of these is so that they can have, so that the bill reduces the deficit. And that's why they have to make these kind of changes, raising taxes by eliminating deductions. So the other thing, as I mentioned, employers wouldn't be able to deduct expenses for qualified transportation benefits, but to the employees, they would still remain taxable, but the employers wouldn't be able to get any kind of deduction. So, excuse me, I know you've heard about, well, what's happening with 401k plans. And while it's not directly related to healthcare reform, I decided just to briefly talk about it because it's important to many of the people that are dealing with the health plans, also deal with retirement plans. So it would leave in place the full pre-tax contribution rate, the $18,000 for 2017 and $1850 for 2018, plus the additional catch-up. One other thing it would do, it would expand hardship distributions, allowing individuals, because right now hardships can only generally come from an employee's money that they put in and not their earnings. But it would allow them to also take their earnings and potentially company contributions, and would also eliminate the suspension of continued employee contributions. So right now, generally, if you take a hardship, you can't keep participating, which means you can't, say if your company gives a match, you don't get that match because you can't contribute. But this would get rid of that, and you would be allowed to continue to participate. So that's the House bill, and that gives you sort of just some of the impact of the workplace benefits as it stands today. But as I'm sure you hear in the news every day, there are different things being proposed and amendments, so it definitely is not in final form. So let's move on to the Senate bill. Well, the Senate bill was just released on the 9th, and while it's similar to the House bill, it does include a provision that non-qualified deferred compensation, which is basically things like stock option plans and other kinds of payments to executives that are deferred for future years, that they will become taxable when there is no substantial risk of forfeiture. And while this may not seem like a big deal, it actually could be a very big deal because it would eliminate what is called Code Section 49A, and all the plans out there for executives have been structured, or at least most of them, to meet those requirements. And if this were to come to fruition, then everyone would have to go back and redo their non-qualified deferred compensation. The other thing that is included in this one, while it does leave the 401k alone, basically, it does limit the catch-up contribution. Remember I mentioned the catch-up. It eliminates that if an employee makes more than $500,000. And although it's not on the slide because it was just offered, Orrin Hatch just offered an amendment where you could it would increase the catch-up to $9,000, but required that catch-up can only be after-tax Roth contributions, not pre-tax. So again, that's already changed a little bit. So that is what is happening on the Senate side. So, I will be, one of the things that I'm going to mention at the end, I'm going to continue to update, and you'll see I have a blog and Twitter, and I do update as things change and as these two bills work their way through. There definitely is a feeling that there will be tax reform passed this year. So the question is, how much of it will impact employer health plans and employer plans in general? So now I'm going to just switch a little bit and talk a little bit more about the individual mandate debate. And as you remember, this is that you have a penalty if you don't have coverage and you can't prove that you have coverage. Well, President Trump wants to eliminate it, but technically he can't because it's in the ACA actual language. So they're trying to figure out other ways to get rid of it. So as you know, right now they haven't released it yet, but apparently they're preparing another executive order that would weaken the requirements. And how we think that they're going to be doing that is by increasing the individuals that can receive a waiver. Because right now you can get a waiver from having health coverage if you make below a certain amount, if you have certain health conditions, things like that, where you can actually get a waiver. So we think that that executive order will include more people that can get a waiver. And we have been told that the White House will release it if the congressional Republicans don't achieve anything through the tax reform process. So it's likely that you will see this issued if tax reform goes nowhere or if tax reform doesn't do anything about the mandate. Because as I mentioned, the individual mandate is a revenue raiser for the Tax Reform Act if they were to include it. And there definitely is a lot of support to put it in the bill, even though it is not in either the House or Senate bill right now. So what comes next? Well, the IRS is still issuing new guidance on the mandate penalties and also has come back and taken a different stance than President Trump, and basically said, if you don't indicate on your tax return if you have health coverage, then we're not accepting your tax return. So they're forcing that issue. Originally, there was discussion that they weren't going to make people answer it, but now they are. So let's go now to the employer shared responsibility payments. On the 2nd of this month, the IRS updated its FAQs, and this is under 4980H. And I won't say that anymore, but I did want to at least give you the actual quote. And the IRS has to collect information from applicable large employers, as you know, more than 50 employees. And for 2007-15, it would have been 100 to assess the penalty. And these were the 1094s and the 1095s filings that were done. And so the IRS has said that they are going to begin issuing actual penalties late this year. So as a reminder, under the 2015, remember each year changes, it was $2,080 for a full-time employee, in excess of 80 if you didn't offer coverage to 95%, or in that case for that particular year, 70% of your full-time employees. And then the 4980HB was $3,120 for each full-time employee who actually went to the exchange and received a premium tax credit or subsidy. So those amounts are adjusted for each year, but that's what they were for 2015. So the new FAQs, and I did give you the link down at the bottom if you want to look at them directly, they've clarified how it's going to be assessed. And so as typical for the IRS, it's a 4-step process. But the reason I'm bringing it up is because the time frame for response is short. So you need to make sure that you have the information handy on your Form 1094Cs and 1095Cs, and it's readily accessible either because you have it or through your ACA vendors. So what I've actually shown, and I'm not going to go through this in any detail, but I wanted to provide this to you, is this is sort of the step, so the first thing is you would get this letter 226J, and then you have to respond, and there's a form for that. And then the second step is the IRS acknowledges that you took further action, and if you agree, then it's a simpler process. If you disagree, then there is a pre-assessment conference request, and then you have the pre-assessment conference with the IRS, and it's via phone, correspondence, or an actual personal conference. And then at that point, there is a notice that is issued after the decision, or you can also go to court. So as you can see, there are a lot of steps in that. And so I did want to just let you know that you're going to be seeing those. So if you get that 226J form, you need to act on it. And so you need to be ready for that. So at this point, well, what are my final thoughts? Well, Affordable Care Act is live for now. You have to keep planning on meeting the requirements, and you've got to comply with the employer mandate. I do believe, I said tinkering, you can use whatever phrase you want, is that based on what's happening in Congress, it's more likely that you'll see, small changes or even larger changes made. Maybe the mandates won't be enforced, the regulations that I mentioned, we could see association health plans, the short-term insurance may, that may start. So you're going to see some of those changes. But, I don't feel that it's likely that repeal and replace will happen this year. I mean, I could be wrong. So I think instead you're more likely to see some of the things that I talked about in the beginning having to do with the association health plans and HRAs and some of the others. You're more likely to see that. So with that in mind, if you have any questions, you can post them using, I guess actually you're going to tell them a little bit about how to do that. But I also want to ask one particular question to the group as a whole. I'm considering doing a periodic 30-minute updates on where the Trump administration and where the House and Senate are on all the different healthcare bills. And so I would like to know whether that's something that, as a group, since you listened to this one, you might be interested in listening to that, whether or not that would be something you're interested in. So if you are, if you would email me directly, or you can email when you ask for the PDF copy, which we're going to hear about in a moment, please let us know your thoughts on that. So thank you for joining us today. If you would like to have a PDF of this webinar, please go ahead and email sgrcommunications@sgrlaw.com, or just say me. You can email me directly. You've got my email information there, and we'll send you one. And for more information on upcoming webinars or events, please contact SGR Communications at SGR Law or visit our website at sgrlaw.com. Thank you very much for your participation today. And as I mentioned before, please give me some feedback about whether you would like to participate in short, periodic updates on what's happening with healthcare. Thank you and have a good day.